Dr. Manavi Sindal. She will be speaking on differentiating PCV and wet tip AMD.
Good morning, everyone, and I think a lot of my work has already been done in parts by the prior speakers. I think I'll just bring it all together. So, as we know, AMD is one of the leading causes of loss of vision, and we see quite a lot of PCV, especially in our population. It's more of a vascular disease of the choroid and is characterized by the recurrent serosanguinous maculopathy, presence of orange nodules, and pachychoroid. And what differentiates it from AMD is the absence of drusen, pigmentary changes, and atrophy. We can use all the various imaging modalities in different ways. Let's go through them. So fundus photography in PCV, you would see an orange nodule, the pigment epithelial detachment, which could be a hemorrhagic PD or a serous PD, extensive subretinal hemorrhage, and lipid deposition. On the basis of this, clinically, PCV is classified into the exudative form, as is seen in the first image over here, where there is more of exudation and more of fluid and lipids. The hemorrhagic form, which can have the hemorrhagic PEDs or the subretinal hemorrhage, and a mixed form of the two. We should suspect PCV clinically when you are seeing the orange-red subnodular nodule, serosanguinous maculopathy. Here you can see in this case you have a large PED. Here you have subretinal hemorrhage, you have sub-RP hemorrhage, a large lesion happening there. When there is disproportionately more exudation, and also when you have used anti-VEGF and there's a poor response to it. ICGA is the preferred modality of investigation for PCV, and the Everest has defined the criteria of nodular hyperfluorescence, hypofluorescent halo. So if you look carefully at this image here, you have the nodular hypofluorescence here, and this one here shows the hypofluorescent halo, and pulsatile, which can be seen in dynamic ICGA. In the first 1 minute of your ICGA for PCV, you will be looking at the branching vascular network, which is seen here in these lesions. And it is in the later 6 minutes that you look for the polypoidal lesions, which are noted over here in this particular eye. Let us look at this patient who was followed up over a period of more than a year, and this is the baseline ICGA, where you can see this is the branching neovascular network seen, and after a course of 14 months you can see that the whole network has expanded so much in size, and these are the polyps which were present initially, and when you look at later, there are a new row of string of polyps and a new onset PED which is seen now in this patient. So here with ICGA you can document the increase in the size of the BNN as well as the occurrence of the new polyps, since these polyps keep on appearing. On ICGA, it could be the macular PCV, which could be subfoveal, juxtafoveal, or extrafoveal. You could have it in peripapillary location, or it could be extra peripheral when it lies outside the arcade. Another example here is a polyp which is seen in this patient, which could be called either juxtafoveal or peripapillary, and here is a peripheral polyp seen in this patient. So the consensus nomenclature has been recently released, which has helped us define a lot of these terms. So one of the terms is that you have to use the term polypoidal lesion and not a polyp, because it's not a solid fleshy lesion, or aneurysmal, because these are not just dilated sub-RP lesion, may not always be present. The branching neovascular network, since this has seen to lie above the Brooks membrane, signifying that it is neovascular in origin, and the term complex or multilobular PED, which combines the previously used terms of notched PED and hemorrhagic or multilobular PED. These are the non-ICGA diagnostic criteria which this consensus nomenclature has described for us, and it has three major criteria. The first is the sub-RP ring-like lesion, the second is the en-face complex RP lesion, and the third is the sharp-peaked PED. You have minor criteria like the orange nodule, the thick choroid, the double layer sign, the complex multilobular PED, and the fluid component was also studied and evaluated but does not form a part of the minor criteria. Looking at these lesions one by one, you have the sharp-peaked PED, which is the thumb-like PED or thumb-like protrusion, inverted V shape with a steep incline of at least more than 70 degrees on one side and a height as to width ratio of more than 1. You have the sub-RP ring-like lesions, which indicate the underlying polypoidal lesion. You can see that here as well as over here. The reflectivity in these may vary depending on case to case. The on-fast imaging, where you have the complex PD, these are the various polyps that you can see. This is from the same patient whose ICGA we just saw. These are all the different polyps, and this is the large PED that you can see on the on-fast image. The complex multilobular PED, which has the what would be called as the notched PED, and you have the area of the double layer sign over here. And the double layer sign, which is the overlying RP undulating with an underlying Brooks membrane. This area typically represents or is the area where your BNN is going to lie, and you'd have your polyp here forming your complex or multilobular PED. And the pachychoroid, which is thicker for age and axial length, and you have a dilated Haller's layer. And the full fluid compartment, so there's definite more SRF than IRF seen in these patients. On the OCT angiography, the polypoidal lesion, the whole lesion has been described to lie in 3 layers. They have noted the polyps to be in the sub-RP space, the BNN on the outer side of the reference plane, and the feeder vessels from the choroid. Again, let us look at some octas. This is a BNN, the same patient we had seen in the ICGA. This is a baseline BNN, and you can see how it has increased. So the octa is also showing you the BNN increasing in size, same as you had seen on your ICGA. And here's another patient who I had followed up for over 10 years, and he's got this large branching vascular network. And if you look at his case history, he had this polypoidal lesion here, which went on to, which was treated. He had this PED here, multilobular PED. At this time, we couldn't image polyps. He went on to later on develop a PED lower lying over here. Then ICGA detected this polyps, which you can see lie at the junction of the older PED was at this area, and the newer is here. So that was a very interesting finding. Went on to be treated for a long time, then developed fluid in the inferior temporal area, and that is when we saw in peripheral polyp also over here. The whole aim of showing this case is that these lesions can appear and regress in various areas with your treatment to appear in different areas in the same patient. So to conclude, polypoidal choroidal vasculopathy is very frequent in our population, and OCT signs may suffice to give you a working diagnosis and manage treatment. ICGA is, of course, very essential to confirm diagnosis, and for the Indian people, for when you need to do a focal laser for extrafoveal polyps, since unfortunately only some exclusive people have PDT available in India. Thank you.
So thank you, Manavi. I think that was a beautiful talk on PCV. In the current, or in your practice, I mean, majority of us now diagnose PCV quite reliably on OCT.
Absolutely.
So for the benefit of all of us, what would be the indications for ICG in a patient of PCV where you feel that without ICG you just cannot manage?
I would do ICG in a patient with PCV when I'm having extrafoveal lesions, which I want to do a focal laser for to reduce the treatment load, and for peripheral lesions. And sometimes if I'm having a very poor response, I may go in for an ICG. But since we don't have PDT, it's really not mandatory to do ICG. Otherwise, of course, you would need an ICG and to do a PDT and a combined treatment.
George?
Basically, I do agree because of the recalcitrant cases is where we currently do ICG, and when there are cases, at least 20% of them which do not respond to any anti-VEGF, even the new, so we combine it with PDT. I think currently we are doing it, but then with limited availability, it's still a challenge actually.